Hello.
Yeah, good evening. Good evening.
Good evening,
Please.
sir. You can start the session. I have opened the room for the attendance.
Okay, thank you. 2 minutes, I will start. So I will start now. So good evening to all of you. Today I'll be showing two short cases before two long cases. So I'll start my screen now. Is my screen seen?
Yes, sir.
Okay, right. So this is given to me by Dr. Srinivas from Karimnagar. It's a short case. It's the story of a 60-year-old lady. History of having had fever for 1 week back. This was followed 4 days later by inability to walk and swaying while sitting. She was also noticed of jerky movements of the left upper and lower limb for the last 2 days. So fever 1 week back was subsided. 4 days later, inability to walk and swaying while sitting, and noticed of jerky movements of the left side, left upper and lower limb for the last 2 days. And this is the video sent by Dr. Srinivas. Look at the eye movement and tell me what you think it is.
ఈ మందులు వాడక 2 నెల 15 రోజులు అవుతాయి ఇక్కడ రాకుండా మందులు వాడితేనే మంచిగా ఉంటుంది. సార్ ఉన్నాడు, ఒక 2 నెలలు వాడు రమ్మన్న వాళ్ళే అలా ఫోన్లో మాట్లాడినా సార్ మీతో. మీరు లేరు 6 గంటలకు వచ్చినాక రిపోర్ట్ కట్టుకొచ్చినాక పొద్దున్న వెళ్తాను.
Okay. Now, so what do you think the patient is having?
Oxyclonus, myoclonus, sir.
Yeah. Yeah, what you observed was an ocular flutter. You are justified in telling obsoclonus also because obsoclonus and ocular flutter has got the same pathophysiology. One can be considered as elder brother of other. Ocular flutter can go on to obsoclonus also. So what is the likely etiology in this patient?
Post-viral adenoma.
Yeah, post-viral is the most common, or can be paraneoplastic as well. Yeah, these are the two common causes, but there are any number of causes for obsoclonus myoclonus syndrome. So let us see the investigation of this lady. This is a short case. Let us see. This is the MRI of this lady. Look at the diffusion weighted sequence. Some diffusion distribution near the caudate head bilaterally. This is enlarged view. This is the flare. Again, see hyperintensity extending beyond that. It's present not only in the head of the caudate, but also below that level also it is seen in the anterior part of the putamen. This is again the enlarged view of the flare sequence. So what do you think the patient is having?
Sir, could it be a dengue fever?
Yeah, it could be. It could be a part of dengue encephalitis because basal angle is affected bilaterally. That's a good thought we have to keep in mind. Very good. Yeah, that's the thing we have to keep in mind. Because obsoclonus myoclonus can follow. I've seen following COVID infection, can see for dengue infection also is a possibility. But she was having jerky movements of confined left side of the body only.
Diabetes also, sir.
Yeah, correct. Her blood sugar is 450. 78 and 3.5. So many, what you said is exactly correct. That many of them do not know that the diabetes ketoacidosis can produce obstructive myoclonus syndrome. They can produce as all of you know, they report the left focal continuous choreothetic movements and seizures, mainly intentional seizures. Similarly, can also have obstructive myoclonus syndrome. And let us see the full video of this patient. This is the flare sequence, sorry, the diffusion sequence, below upward. That's hyperintensity same there. And diabetes can produce bilateral, even though symptom may be on one side, the hyperintensity can be seen, the baseline abnormality can be seen bilaterally. This is the diffusion area weighted. You find some diffusion restriction below that, whatever you have seen in the caudate nucleus, not exactly at the same site. That's area, but that area there is no diffusion restriction. I will show the screenshots later on. This is the T2 weighted sequence. Again, find hyperintensity there. That look more like an infarct rather than what is seen in diabetic striatopathy. This is the flyer. That it is hyperintensity. Both are hyperintensity in the flare sequence. The one showing the diffusion is on the uppermost part. So any other sequence you want, see what characteristic finding in MRI.
T1.
T1 weighted sequence. Let us see the T1 weighted sequence now. Otherwise, you can easily confuse with the infarct. T1 should hyperintensity. You can see the hyperintensity in the same area where there was a diffusion restriction. So see this is the T1 weighted sequence. You can see the hyperintensity there on both sides. This is corresponding diffusion weighted sequence. The corresponding ADC, there is no diffusion restriction per se, no hypointensity. This is the flare sequence with the corresponding area. Just the cut below that you find hyperintensity in flare as well as in T2, and that area is showing. Sorry, this is not. This is the ADC showing diffusion restriction in the parts below that thing, and there is hyperintensity in the T1 also. So probably there may be, apart from the striatopathy, maybe an associated infarct is there. I cannot say it is not there because of the diffusion restriction seen in that cut below the one which you are seeing the diffusion restriction. No diffusion restriction, diffusion hyperintensity in the upper part. So most likely diabetic striatopathy with probably an associated infarct. The question is, why should infarct and striatopathy occur together? That's the problem, no? So it's very unlikely that two diseases to occur at the same time. So this is case reports. Sometimes they can coexist together for unknown reasons. Diabetic striatopathy complicated by acute ischemic stroke. And this is the one showing that the MRI picture from that article showing the infarct as well as the striatopathy. This is the another picture. And remember that striatopathy can be bilateral, need not necessarily be unilateral. This is another case showing bilateral involvement, just like our patient. This is again another case with bilateral striatopathy. And this is one manifestation of refractory myoclonus in hyperosmolar hyperglycemic state. Okay, it's a short case only. Any other questions in this case?
No, sir.
Okay. So we'll go to another interest. This is again refractory myoclonus and hyperosmolar hyperglycemic. There are many articles referring to this condition. Now I'll show you another one. This is a 60-year-old musician. In fact, he came from a long distance because he was very much worried about his problem of problem. I'll tell you what the problem was that he could play his musical instrument. He could not play his musical instrument as before for the last 6 months. The musical instrument which he was using was Nadaswaram. When he plays that instrument, the sound gets distorted, sometimes gets stopped in between. As goes on playing it, the sound gets distorted and sometimes broken. So I'll show this is the picture, the video he has sent, his problem. Sound is distorted now. Now see the other part, this is again, this is another video. The difficulty he has now. He cannot sustain a note. It gets interrupted in between. So what is the diagnosis in this patient?
Sir, is it a musician dystonia?
Dystonia.
Yeah. So this is exactly. It's a musician dystonia, perfectly right. Just like any other occupational or task-specific dystonia. Okay, so what will you do now in this patient? Now, he is so much upset upset and worried about this because he's affecting his profession, the only profession he knows. So he has seen a neurologist and many persons put on Revocon, Pacitane, etc. with no relief. He is presently on Parkin 110 for the last 3 weeks, along with other medications like vitamins.
Botox can do it.
But see, this occupational dystonia, Botox, where will you give the Botox? Because to make a musical note, many muscles has to be known, no? Facial muscle, laryngeal muscle, pharyngeal muscle, where will you inject? And they see the complications which can occur with to inject the muscle. I do not know whether anyone has given Botox injection for musical dystonia. Maybe. I do not know.
First, sir. Voice rest.
Pardon? Voice arrest. Okay, that's so. But this is only profession. Okay. See, this is after treatment. The one on the right side is the patient. Left side is his brother. This is another part of the same patient after treatment. I'll fast forward. So he is much better now. He's very happy that he could go back to his profession. He said that 95% better, but still 5% is remaining. And only better. It is great that you got that much about the relief. So what was the treatment given to him?
Syndopa.
With the help of other person.
No, Syndopa.
With the help of other musicians, sir.
Pardon? No.
With the
He
help of
says
other
he-
musicians, treatments.
Help of?
No, taking the help of other musicians, intermittently.
No. Now, what I did was that I increased the dose of Pacitane. Nothing great, 2 along with diclonazepam. Now you may choose why I was not sure whether this person will improve with Pacitane or not. But I had an experience in the past. That is why I made myself to think about in these lines. See, this story goes back to many years back when I was in Kottayam Medical College. So when he is a barber, he cuts the hair. So he came to me with the complaint that whenever he cuts the hair, the scissors will go in a wrong direction and 2-3 times injured the ear of the customer. So you have to stop the profession. So he came to me at that time. I put some medication. I never came for follow-up. 2-3 years later, when I was walking down the town of Kottayam, somebody came in and catch hold of my feet. I thought some enemy or something was angry with me, is pulling my leg down. So I got frightened. Then suddenly, he got up and said, "Sir, the years back you treated me. I'm back to work now. No, I have totally forgot about it." Then he told me, "So the medicine which I gave me earlier, still now I'm continuing. In between I stopped, the complaints came back. Now I am working perfectly as a barber." Then I asked, "What medication have I given for you?" I have given Pacitine at that time. So sometimes Pacitine, even though it's an old drug, may work someday very well. That person who has been remaining asymptomatic for many years, he could go back to his work as a barber. So this person also has got good improvement in the Pacitine. But make it a point, you have to increase Pacitine slowly, not 1 TDS, 1 BD. That when I would have patients on 3 tablets 3 times daily. Some people may not tolerate, agreed, but you have to gradually increase up to this level. Some of them do respond. In those situations where Botox can't be given. So any questions?
No, sir. Thank you, sir.
Yeah, in fact, I had written my case sheet that the patient does not respond. I will try high dose of tetrabenazine, but luckily he responded to Pacitine. Okay, now go to the proper case. The story of a 21-year-old female. I seen the patient on 2/9/24. That is 2 days back. He had a bike accident on 21/7/24. That is about 1 month back. Nearly 6 weeks back. Following which he became unconscious at that time. On recovery from the unconscious state, he noticed difficulty in elevating his left upper limb. The usual story of an accident followed by injury to the plexus or whatever it is. He was being followed by the orthopedician for the last 1 month. Since there was no improvement, he referred the case to me. This is the video of the patient. I will show him in detail. There was no Horner syndrome, or normal. The shoulder elevation was normal. That's the right side is normal. Left side deltoid was 0, almost 0 power. Biceps was again 0 on the left side. External interrotators were also weak. He could not do the external rotation nor the internal rotation. Triceps also weak. 0 to 1 power for all the postural muscles. This section was weak on the left side, but not 0 power. 3 to 4 power on the left side. Finger extensions were also weak, about 3 power. Flexion of the wrist was weak. Actually, it was weak actually later on. Finger flexors are normal on both sides. That's also normal. All muscles are all normal. Extensor pollicis longus is weak on the left side. More flexor pollicis brevis is normal. See, the inward movement of the wrist is normal. That is, radial deviation is weak. Ulnar deviation is normal. Flexion of the wrist also is weak. Biceps, supinator, triceps are all absent on the left side. Yes, I'll show the he's got impaired pain over the lateral aspect of the forearm, the lateral aspect of the arm. Medial side it is normal. There it is normal.
Normal.
It's normal now.
Sunday.
Normal.
Ide. 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 Normal thana.
So in the palm, it's all normal.
Ide.
Then it's also normal. There is impaired. Between the web space between the thumb and the index, there is decreased.
Kami.
So,
இல்ல
vibration is
பூர்ண தெரியுதுல
impaired on the
இதே
thumb.
மாதிரி தெரியுதா இல்ல இப்ப தெரியுதா
All of the fingers is normal.
இப்ப தெரியுதா தெரியுது
Joint sense
மடக்கி பம் ஸ்ட்ரைட் ஆக்கி ஸ்ட்ரைட்
normal even in the thumb.
டவுன் இப்பம் அப் பம் பம் டவுன் பம் டவுன் சரி எந்திரிச்சு
So summarize the finding. Yes, weakness grade 1 of the left deltoid, left biceps, internal external rotators and triceps. Wrist flexion weak on the left side. Finger flexors and flexor as long as grade 4 plus almost normal, but wrist flexion was weak. Wrist extension, finger extension is weak, grade 3 plus to 4. Wrist adduction was normal, but abduction or radial deviation was grade weak. Small muscles of the hand were normal. So here we weakness grade 0 power of the deltoid, biceps, external internal rotators and triceps. Wrist flexion was grade 4. Finger flexors and flexor pollicis longus grade almost 5. Wrist extension, finger extension is grade weak, 3 plus to 4. Wrist adduction was normal, abduction was weak. Small muscles of the left hand normal. DTR all absent on the left upper limb. Sensory impaired pain over the palmar aspect of the left thumb and over the lateral aspect of the forearm and arm. Normal over the dorsal aspect of all fingers, but impaired over the web space between the thumb and the index finger. Impaired vibration in the left thumb, normal in all other fingers. JP sensation is normal in all the fingers. So this is the sensory loss. This is on the back. In the back, it is not extending up to the shoulder, but still I'll show you. This is the areas affected. Extending down up to the dorsal aspect of the thumb, as well as the web space between the thumb and index finger. If you're looking at the front, it is sparing the index finger, sorry, sparing the thumb also. All the hand is spared, the palmar aspect. But since this loss is confined to this area, vibration is impaired of the left thumb, JP sensation is normal all the fingers. So where is the localization? If you want the findings once again, I will tell you. They want to see the
Proximal
video.
muscles, sir.
I'll show the proximal muscles. You want the video or the findings only?
Sir, supraspinatus rhomboids, sir.
Wrong. I'll come to that. See, he's got 0 power, almost 0 power of the proximal muscles. So checking the rhomboids, etc., will be very difficult. I'll tell you, I made him examine. I'll show you the examination which I did later.
C5, C6, C7 root, sir.
Correct.
First possibility.
Yeah, right. Very good. C5, C6, C7 root or
Upper and middle
Upper
trunks.
and middle.
upper middle
Like
trunk
the
or very good, very good. Perfectly right. Or can it be a lateral cord and the posterior cord? Let us analyze this problem. What you said is perfectly right. So relation could be C5, C6, C7 radiculopathy can explain everything in this patient. Upper and middle trunk can explain. Or lateral and posterior cord can explain. Correct? Because
Yes, sir.
yeah, lower trunk continues as the medial cord. The only muscle separated by the C8 is the extensor indices, but that we cannot be certain here. So it can be all the 3 possibilities. Okay. So first question, how to differentiate C5, C7 radiculopathy from upper and middle trunk?
Rhomboids, sir.
Rhomboids as well as
Serratus anterior.
serratus anterior. Perfectly right. Perfectly right. So I tried to do the serratus anterior, but the problem is that triceps is zero power. So I was holding his elbow like this, behind there. But even you cannot put pressure on the wall because you have to keep it extended. No, that is very become difficult. So I still tried to examine him. Then putting pressure on my back, asking to pull backward. He could not do that because he's doing with the right side, not with the left side. Rhomboids also, he cannot keep his hand steady onto the hip. This is a problem in examination with the weak muscle because unlike other joints, the shoulder muscles hold the head of the humerus in situ. The muscles are weak. You cannot examine properly the arm muscles. Why? Because here we are utilizing the arm as the lever. When checking the push-up against the wall or checking the rhomboids, you are not directly examining the muscle per se. We are using the arm as the lever to examine the muscle power. You understood what I said? So if the muscle cannot be held steady by the fixators on the shoulder, you cannot examine either the rhomboids or the serratus anterior. It may be faulty. It may be, as you can see, there is no winging. I'm not very sure because of the technical difficulty in examining these muscles. So there's a very big problem differentiate between this is very crucial in our patient, but unfortunately that is not very valuable in this patient. It appeared that those two muscles are normal. However, testing was difficult since you could not keep the elbow extended because of the severe weakness triceps to serratus anterior. Serratus anterior, you have to push against the wall, no? For that, you need triceps also to keep it steady. He could not keep his hand on the side of the trunk in view of the severe weakness of the shoulder abduction. So, because of the severe weak shoulder muscles, the arm could not be used as a lever. Because you remember that you are using the arm as a lever only. To check the rhomboids, you are using the arm, putting pressure on the arm. See, the arm cannot be stabilized. How can you check the rhomboids? So the problem now, so we cannot differentiate the two with available evidence. Now come to the next problem. Why can't be lateral posterior cord? Which muscle examination help to differentiate the two? Suppose this patient has got lateral cord and a posterior cord involvement. Can't it produce the same phenomenon? Very difficult, extremely difficult. But the only muscle which you can examine is extensor indicis and extensor carpi ulnaris because they are separated through the C8 root through the medial cord. Okay, not medial cord, C8 root through the posterior division of the lower trunk, which ultimately joins the posterior cord. So extensor indicis can be spared in C5, C6, C7 radiculopathy because the main supply is C8, but invariably affected in posterior cord. Posterior cord can be invariably affected, but can be spared in C5 to C7 radiculopathy because its root innervation is mainly C8. But again, there's a caveat in that extensor indicis also has got a contribution from C7. So again, we are at a loss. But if it is spared, of course, we can help to differentiate. If it is affected, we cannot help to differentiate because it may be affected even in C5, C6 because C7 contribution is there. Okay, now we are at a loss now. So what other investigation you want? We want to differentiate root from trunk versus cord.
Sensory.
Okay, NCA study. In fact, patient has NCA 2 times, it is done 2 times. This is done after 2 days. Pardon?
7 doubt second sensory examination differentiates, sir. He had a pattern of sensory loss, no, sir.
No, that cannot differentiate because that also favors what C5, C6, C7 also. It also same because ultimately the same dermatome is the same root is contributing to the upper and medial trunk. It is always the same pattern only because the C7 continues as the middle trunk. So there is no separate branch from the middle trunk or the C7 root separating out just like our serratus anterior or anything to differentiate between the two.
Okay, sir.
Particular, yeah, because C7 and middle trunk cannot be because it continues as a middle trunk. Okay. So this is NCS done 2-3 days later. You find there is decreased CMAP amplitude from the left deltoid. Biceps, it is not done. Then supra days. Sorry. Can you see my slide?
Yes, sir.
Okay,
Yeah.
okay. There is some connection problem in between. Okay, the left median amplitude is normal, radial was normal, left ulnar was normal, but all done on the left side. There is no comparison from the other side. This is sensory conduction. The ulnar median normal, radial normal, and ulnar. This is FA studies again normal. So what do you think after that? Does it help you in making a differentiation?
Sensory is normal.
Sensory is normal.
Yeah.
And the point is that you cannot rely on a data done 2 days or 3 days later because the sensory potential become absent only after 10 to 11 days. And CMAP amplitude can become low only after 5 to 7 days. Sometimes it may occur early if it is possible, but to rely on the NCS data or EDS data, you have to wait for at least 7 days or 5 to 7 days for the motor findings to appear, and at least 10 days to 11 days for the snap to disappear if sensory is affected. So this study is not going to help us. Okay. So what do you want now? Repeat contraction. Okay. In fact, patient came with a repeat EDS report. And that is done 1 month later. So that is sufficient time for the electrophysiological abnormalities to appear. So whatever is seen can be relied upon. Again, you see that deltoid amplitude is low. Left median amplitude is normal. Radial amplitude is 5.15. There is no comparison on the right side. Left ulnar is 12.66. Again, normal. Sensory, median, normal, radial, normal, ulnar. FA, normal. So, is it root or is it whatever, upper trunk, pyramidal trunk? What do you think? Am I audible?
Yes, yes.
Yeah, okay.
Yeah.
Yeah, please tell me. Well, yeah, this is, you have to think, you have to different between the differentiate to think how this ED is going to help. So you must know each and every point in the EDX parameter to differentiate between the two.
Maybe in the root, sir.
Maybe in the root. Why? Because the snap is preserved, correct?
Sir.
Okay, right. Snap, because snap preservation snap indicating that the lesion is preganglionic. Position snap should be absent. But remember, let us see the question. I'll come down to the question. Is root avulsion or brachial plexus injury? As you said, maybe proximal to that, it says following trauma, it indicates a serious condition like root avulsion. It's not going to recover because the snaps are spared. Okay, that's what you're thinking. Okay, right. Now, is the EDA satisfactory? Can you rely on this EDX in NCS finding?
No. You have to
Why?
compare.
One, you have to compare. Second, but even whatever the available, it's a good sense snap amplitude on the left side. It is +7, a good amplitude, 30, 40 in the range.
Because the upper and middle trunk EDX, ulnar, median, at the most radial we are doing. We are not
Correct.
measuring the upper C5, C6 system.
Very good, very good. That's the thing. So what now will you like to do?
Axillary.
Axillary, you cannot sensory. What sensory is there from the axillary?
LABC.
Left and
Ah,
LABC
correct.
and MABC.
Correct. That's answer I want. So always when somebody comes to you with electrophysiological data, always think carefully whether that can explain your finding. Is it done correctly or wrong? See, when you just like do NCA study, they will go to the routine study and send it to you back. And don't rely on that. So you have to think carefully. So let us see. So what happened? This patient was also MRI was also done. I'll show the electrophysiological data because I have to repeat that because to the LABC and MABC. So MRI was done. Why MRI is done?
To rule
Because
out root avulsion.
root avulsion. This MRI the patient came with. This is the surgical cut. This is the coronal. Coronal, you see, you cannot no pseudomenial can be made, but marked edema and condition can be seen in the region of brachial plexus. The muscles are all very hyperintense. There's there is some trauma which has happened in that area. See that degree of hyperintensity is seen in that area, the soft tissue and the subjacent scalenus triangle and all. That is the region of the brachial plexus here on the right side. Here it is seen here. But no obvious pseudomeningocele. So he has brought with this MRI, does not show pseudomeningocele. On the other hand, a contusion in the region of the brachial plexus. Electrophysiologically, it's not going to help us because proper NCS was not done. So what will you like to do now? You want, I will give you.
NABC,
Pardon?
LABC, MABC, LABC.
Okay, right, perfect. So
And
let us see that.
pseudomendocele takes time, sir. It will not be
Is?
seen. It will not be seen immediately after the
Right,
treatment.
right, perfectly, correct. That can be seen even in the very beginning, it can be seen. So, why do you want to repeat EDS? Because the snap, the point is that, again you remember this point. Here his thumb is affected. Okay, he has got impaired vibration sense in the thumb, but sensoryless thumb. But the medius also should show abnormality, correct?
Yes, sir.
C, yeah, C6 is supplying the C thumb also. Thumb sensory is affected, but the snap on the median is normal. So can we take it as a evidence of root involvement and not plexus involvement? Can anyone tell the reason? I will not take that point into consideration. Can we tell the reason? There are two reasons. One, his joint sense is normal on the thumb. That means the large conducting fibers are preserved. So that cannot be helped. More importantly, when you do the routine nerve conduction, where will you put the sense electrode for the snap? For the median conduction. Sensory conduction. Index finger, digit 2. Okay, this is because many of you don't do this, that are not doing it, only the technician does it. So it is done from the second finger, not from the thumb. His second finger is totally unaffected. Thumb is the area we showed the sensory loss. So if at all you want to do a sensory conduction, this is all applicable for root and plexus lesions. You have to find out the area of the sensory loss and put the electrode in that area. Otherwise, if you put electrode in the normal area, it may be normal. It is not a nerve lesion, remember. The lesion has to be in the root or plexus. That particular fiber is the one which you are interested in. Because snap of the median nerve is not enough because the affection of the thumb is only partial and JP is normal in the thumb. And moreover, the snap is usually done from the index finger, which was not affected in our patient. So that is one reason to do that. The second reason, so what instruction will you give the technician? To do snap from the thumb and do the snap from the lateral antebrachial cutaneous nerve. We are not much interested in medial antebrachial, but can do that. But more important is the lateral antebrachial, because that is the area where the patient got sensory loss. Sensory loss in the outer aspect of the forearm. So we are interested in the lateral antebrachial cutaneous nerve. So this is the sensory context. It shows normal amplitude even after 1 month, 6 weeks. And that is the area of sensory loss. At least partial sensory loss. So what is the diagnosis? Root avulsion, correct? Okay, is normal. Was it a root avulsion? So what else will you look for? So proximal context of the motor nerves also is part of the study. And this is what has happened in the proximal context. See look at the nerve, median nerve and ulnar nerve, that it has no response from the Eps point. But below that there is good amplitude. Same with ulnar nerve. Radial is okay, and no response from the axillary and musculocutaneous as expected. So what does this tell you? There's got a conduction block there in the Eps point. So as he got a brachial plexus injury, or is it a root avulsion, or both?
LABC, sir, LABC is lower compared to the.
Definitely, LAB is not lower. I'll show that. It's 18 and 17. On the right side, it is 18 and left side is 17.
And that ring electrode on the thumb, sir? Was it
Ring
there?
electrode on the thumb, that was not done because I did not repeat it. Because I already got I'm more interested in lateral antebrachial cutaneous now. Because thumb was not totally affected. So I thought that may not be useful. So what do you do now?
EMG, sir.
Pardon? EMG is not
Mainly
good.
EMG, sir.
Yeah, but how can it help?
Sir, as the absent presence, we can think of plexus now, sir.
No, the NC's innervation may be there, whether it's in the root or in the plexus. Anyway, it is still to the anterior horn cell. Both will show the abnormality in the innervation. What is our idea? Are we dealing with a sinister condition like root avulsion or something which is a reversible condition like a brachial plexus injury? We have got traumatic condition, you can see the MRI there. Only odd point is the snap preserved in the lateral antebrachial cutaneous nerve. They'll find some conduction block there in the brachial plexus.
EMG of paraspinal.
Okay, you can do the EMG of the paraspinal, agreed. That can we do that, right? But I did not do that, but anyway.
There may be a combination. So
Yeah, it may be a combination. But the thing is that, see, I purposely misled
a root avulsion, but maybe a root of the brachial plexus. Brachial plexus root is.
When I say plexus, we mean root of the, including root of brachial plexus only, postganglionic. Root of the brachial plexus is postganglionic. That comes as a part of the brachial plexus. There also snap should be absent if it is affected. When we say root, we mean preganglionic. That is the situation only where the snap will be preserved. But remember, see this, where is the conduction block here? The median and ulnar nerve. We are not interested in that nerve.
Yes, sir.
That is not important. So what you find a conduction block or not, so what? That not explain. We want a conduction block in the other muscle we are tested. The one which is having there already the axon is not, CMAP is not there. So this is not going to help us. Okay. So this value has no relevance with particular type of patient.
So they may be
Snap
just
and lateral
technical
antebrachial
only?
is, pardon?
They may be just technical only, or maybe
No, they name because it's got severe condition there, no edema and all. You say the MRI, so they may be most likely technical. So index snap on the lateral fibers root avulsion, conduction with the ulnar mid fibers plexus lesion. But no, this conduction block has no significance in our case because the muscle supply of the median ulnar are not affected in our patient. So there is no relevance. The conduction block may be due to technical reason as Professor telling, most likely due to the local edema because it's got condition there, no local edema there. So most likely root avulsion. So what will you do now? But again, I want to be very certain because when you say root avulsion, you are going to give very, very bad prognosis.
Repeat MRI, sir.
Correct. Repeat MRI. No, I tell you the reason why I repeat the MRI. This should not happen to you again. See, this is MRI done in our hospital now. See, this is the T2 weighted sequence. You can see the CSF and all. See what is happening now? Here you can see the pseudomeningocele. He has got the CSF collection there outside the spinal cord. And below that, see that at multiple 2-3 levels it is there. C5, C6, C7. This is the pseudomeningocele. This is again coming out through the foramina. Okay, can you see the pseudomeningocele? See the corresponding cut, and see the video of that thing with the marker put on that thing. It's the marker. You can see the marker going and the pseudomeningocele on the other side. That is a spinal cord level. Then moving towards the meningocele. Line is put. So there's a meningocele there. C5, C6, C6, C7. That is the area which is affected. Okay, this again in the static, screenshots. This is at the level of the left side. You can see the pseudomeningocele on both sides, C5, C6, C6, C7. Again, you can make it there. You can see that this is on the right side. No meningocele. So, see, the point is that many people, many times, no, the people wearing MRI from outside, but the proper sequence has to be taken. Here, what I did is this sequence or a space sequence or the T2 weighted sequence, proper T2 weighted to show the CSF intensity of the section. Otherwise, what will happen? It will got all smudged out. Will not pick out this thing. In fact, I discussed the old MRI shown by the patient to the radiologist. He said, sir, this is not enough. You have to take proper sequence to find out the CSF, either you have CIS or a space sequence. That is repeated the MRI. Thoroughly picked up the pseudomeningocele. So if he had done a proper MRI earlier, it would have solved all the issues, all the further investigations, sensory study, everything can have been avoided. So that's the thing. That's the thing about this case. So any questions?
But sir, the C6, C7 was not having much weakness. Mainly was in the deltoid, no?
No, C5, C6, and C7. Deltoid was weak, biceps was weak, triceps was weak.
0 in the deltoid, but there is no pseudomeningocele there. C5.
That's correct. But it's all meningocele indicate only that CSS compound that along that place. That does not necessarily show the root involvement. Root may be torn from the cord above also, but the CSS may track downward. The site of meningocele may not necessarily indicate that. Someday the pseudomeningocele may come down up to the thoracic and anterior chest wall. The CSS may track down to the chest wall. There may not only minimal CSS may be there in the spine, but it may meningocele in the chest, because the CSF may come down. The site of the meningocele does not correspond with the nerve root avulsed.
All the snaps were normal, no, sir? How will you explain that?
That's because
Yes.
the deletion is the root, big ganglionic.
Yeah. It's because of the root.
The root only, preganglionic.
Then
Because the routine, yeah.
one more thing is in the first NCS which was done on the day 2, was showing that deltoid was showing a reduced CMAP amplitude.
CMAP amplitude, correct.
So at day 2 also the CMAP may be reduced.
Yeah, that is what that's also I was wondering why it should be reduced. So either the date given one may not have been correct, or because of the proximity, the degeneration of the deltoid is close to the brachial root involvement. That is, the degeneration is occurring first there. On the other hand, if the root is affected affected here, it will take 5 days or 6 days for the thenar muscle to become show the low amplitude. But deltoid is close by. That may be the reason why CMAP will reduce the deltoid.
Sir, will H reflex help?
H reflex is in the usual upper limb is only done from the flexor radialis. It can be helped, but routinely we are not doing it because it's technically difficult.
Why it is called a pseudo, sir? Pseudo meningocele. Why pseudo?
Because it's not a true meningocele, it's because only because of the avulsion of the root has come out from the cord and is pulling the meninges along with that. That is said because pseudo meningocele. It is not due to a real dural abnormality, just like a meningocele which you usually get.
Sir, how to explain the presence of SNAP, sir?
That's what I'm trying to say. If the lead CO2, for the sensory potential, if you look at the sensory nerve, the afferents come from the periphery, go through the nerve, and the cell body is actually situated in the dorsal root ganglion. It is a bipolar neuron, which has got a peripheral process. That is the one which is present in the peripheral nerve. The central process on the dorsal root ganglion, bipolar neuron, go up through the posterior column. So that the central process ends in the nucleus gracilis and cuneatus. It is only so one nerve, one cell body there. One peripheral process goes to the periphery in the peripheral nerve. The central process goes through the posterior column. So if to produce SNAP abnormality, the lesion should be either in the ganglion or distal to that. The lesion is affecting the central process of the ganglion or central process of the dorsal root ganglion cell. The peripheral process will not die because the cell body is intact. Only the peripheral process will die. The central process is affected, so you will have sensory loss also, but SNAP will be intact. That is how you can. That's one of the good. That is somehow differentiate a sensory in a person with sensory loss, whether the lesion is preganglionic or postganglionic. The ganglion is affected.
Sir,
Okay,
here
yeah,
it is
please.
preganglionic, no, sir.
Here?
Here it is preganglionic only, no, sir.
Yeah, it is preganglionic. That is a
Then-
SNAP is present.
Okay, sir. Thank you.
Yeah, okay. It's preganglionic. If the ganglion also got affected, SNAP will be absent. Because if SNAP is affected, both the ganglion is affected, both the central process will degenerate and the peripheral process also degenerate. So that is the way in ganglionopathy, you can get loss of SNAP as well as hyperdensity in the dorsal cord after some time, mimicking some subacute combined degeneration. Because you might think that's a cord lesion, but the problem may be in the ganglion. Because the central process going to the posterior column, that also degenerate and produce hyperdensity in the cord.
Okay, sir. Thank you, sir.
If the dorsal roots are affected, sensory roots also affected, the same thing will occur. They can show hyperdensity in the dorsal column, but peripherally SNAP will be normal. Okay. If the distal to the ganglion is affected, there is central process will be spared. Nothing will be there in the posterior column. It will be intact. But you get absent reflexes and absent SNAP. Reflex will be absent whether it is preganglionic in the root, the ganglion, or distal to that. In the posterior column, reflex will be spared because the reflex is only It's connecting with the same in the same segment itself.
Okay, sir. Thank you, sir.
Okay. Any other questions?
Sir, for the brachial plexus thing,
Yeah.
the root of the brachial plexus can be both preganglionic and postganglionic also. Postganglionic thing
No.
is also called as root.
No. In fact, actually, the term root is quite misleading. It should be called it should be called a radical. Actually, it should be called as a radical for the real root. The root of the brachial plexus is actually the primary rami of the ventral root.
It is only the ventral root.
That is a primary rami is forming the, see, if you get the spine, the dorsal root, so-called dorsal radical, I call it radical, coming to the spinal cord, or the ventral radical. That joint forms the spinal nerve. The spinal nerve divided into dorsal primary rami and a ventral primary rami. The dorsal primary rami go backward and supply the paraspinal muscles. That is why Bindu was telling you the paraspinal muscle to do the AMG and all. The ventral primary rami of the C5, C6, C7, D8, D1 forms the brachial plexus.
That is
The ventral primary.
That means it is postganglionic. It is postganglionic.
That is postganglionic. So that means, so unfortunately, the root of the brachial plexus is also given the same. That's a very misnomer. That I have written in my book, this is a misnomer actually. That should not be used. We want so differentiate that, better to call the preganglionic one as the radical. The root of the brachial plexus is the root of the brachial, or otherwise specify it's the root of the brachial plexus. Then you can understand. Otherwise, you get confused. When we usually say C5 root, we actually mean inside the cord.
So when you give a localization, you have to tell about see, this root of the brachial plexus is involved. C5, C6, or C7 root involved means you mean to say
it means it is postganglion. If it's a root of the brachial plexus, it's a plexopathy. Some or other that term has come into into the our common in this thing, what do you call dialogue. Then we cannot say what do you mean by that thing? But people usually use root for a root involvement, classical root, radiculopathy involvement. If it is plexopathy, plexus involvement, you would specifically say root to the plexus. Otherwise, you'll get confused.
So once there is a radical involvement in brachial plexus, that means it's avulsion only. No.
Then we don't call it a brachial plexus. When the radical is affected, it's called root avulsion. It's the radical affection. In fact, avulsion.
Pathologically, it can be avulsion only. Nothing more, nothing less than that.
No, nothing less. No, if in a traumatic situation, it is avulsion only. Because on the other hand, there is a mass lesion and all, you can compress the root. That's a different spondylotic compression, osteophyte compression. That all can compress the root inside the spinal canal. But in the traumatic situation like this, when there is root affection, how should it occur acutely? That's invariably most likely root avulsion. And the proof is that this pseudomencosis. That shows that the nerve rootlets have been torn away from the cord.
There, again, the motor and sensory both will be avulsed.
Yeah, it may be avulsed, correct. Someday it may be pure motor, some may be pure sense. There is some disparity can occur in pseudomencosis, in the root avulsion. Usually, logically, when you get both can get avulsed. Both ventral and dorsal. It actually multiple rootlets that get avulsed.
Thank you, sir.
Okay. Any other questions? Now, this diagram, I think which I'm showing now, this is a very, this depicts very clearly the supply of the C5 root, which is going through the various trunk and cords, etc. That is a good thing for C5 motor pathway, C6 motor pathway. Then we can know that if C6 is affected, which of the muscles is likely to be involved. This is a C7. See, looking here, the C7 continuing as a middle trunk. It will be essentially the same. This is for the C8 motor pathway. Okay. Shall I go to another case or stop here? One more case. Okay. It's also a little long. Anyway, the story of 44-year-old female. Her complaint started 1 month back as slurring her speech, which has been worsening for the last 2 weeks. History of mild dysphagia for fluids, that's one leading question, but only complaint dysarthria. No symptom referable to other cranial illness now. No other complaint. No headache. But there is some interesting passes. 2 years back, she was diagnosed with fungal meningitis and treated, and is perfectly all right till 1 year back. This is a story given by the patient only. When she was admitted into that, I asked what was your symptom at that time when you was diagnosed with fungal meningitis. Her complaints at that time was headache, diplopia, polyuria, and polydipsia. And all the complaints improved with treatment for 3 to 4 weeks. We do not have the records at that happened 2 years back. But that carried a label of fungal meningitis. In fact, 1 year later, she had developed again another symptom, facial elevation to one side, dysphagia and nasal irritation. And these complaints also improved treatment over a period of 2 months. So 2 years back, she had one set of diplopia and polyuria, which improved. Then 1 year later, she had the facial deviation and tensioner palsy, again, that also improved. Now she has come with dysarthria. This is the video of the patient. I'm asking, the eye movements are all normal, no Horner syndrome. The facial movements were normal, orbicular is normal. Actually, the only abnormal pain. See, look at that jaw muscles were normal.
Like that.
See, tongue is deviated to the right side of the floor of the mouth. Every movement is normal. But putting the tongue deviates to the left side. Movements were normal, almost normal. And she cannot put pressure on the cheek onto the left side. See, it is weak on putting the pressure on the left side. On the right side, it's okay, good power. That is weak onto the left side. The sternomastoids are weak, normal. All other no long joint signs. So I will show that our particular video of the tongue involvement again. See the tongue involvement. See, inside the mouth, it is deviated to the right side. When putting out, it deviates to the left side. That's a deviation. So that's all the finding. So where is a localization? Simple.
Skull base, sir. Base of skull.
Oh, okay. Is it element palsy or element palsy? It's a clear element palsy. Why is
Element.
Okay, very good. Why element? Why not
Wasting
you?
is also there, sir.
Wasting.
And also the
Wasting,
inside.
but the wasting but can be might not be very correct. Maybe more important fact.
Sir,
So
when tongue is
deviation inside the mouth, sir.
That's a
fixed
point.
at the side, sir.
Right. In human lesion, there won't be any deviation of the tongue inside the mouth. Because apart from the genioglossus, all the muscles have got a bilateral representation. So human tongue palsy will become manifest only when you put out the tongue out. So in the case of element palsy, the tongue deviation will be to the normal side, inside the mouth. But to the affected side when you put it out. So here tongue is deviated to the normal side inside the mouth. But putting it out, it deviated to the paralyzed side. So that clearly shows it's an element 12th nerve palsy. That's the point. The resting process inside the mouth will be normal in human, it will be deviated and element. Okay, so what is the base of the skull lesion? Perfectly right. Now I'll show you. In fact, this patient was admitted in another hospital from where he's referred to me. And the investigation at that time is given below. I'll show one by one. MRI done in the previous hospital, there's done 1 month back. This is the T2 weighted sequence. Upper neck. This is the foramen magnum region. Base of the skull. That is the base of the skull here, clivus region. That is the internal aortic meatus. Here the aortic meatus, cochlea, midbrain, etc. This is the coronal cut. This is a contrast done at that time. From below upwards, neck. So this is the MRI done in that 1 month back. So what abnormality did you find there? I'll show the involved area. See, there's got a enhancing lesion there. Okay, the region of the left, say the cerebellomedullary region on the left side. Some suspicion of a hyperdensity, the neural thickening on the right, on the other, in the lower cut as well. So this is the report: mild thickening and abnormal during the posterior first in the anterior and left anteroinferior aspect. No other things are all normal. So there's some kind of a focal pachymeningeal involvement on this particular patient, that area. So in fact, they've done extensively when they're investigated in that hospital. CSF was done. This is CSF protein was 31. Sugar was normal. CSF ADA was normal to tuberculosis. Then CSF bacterial culture was negative. Cells, 11 cells, 9 majority lymphocytes. Then smear show few lymphocytes and occasional neutrophil, no malignant cells is seen. Then did the fungal stain. CSF AAB was negative. Fungal stain was not seen. Gram stain, no pustules or organisms seen. Indian stain, no capsulated organism seen. CSF for mycobacterial tuberculosis DNA was negative, not detected. Blood chemistry all normal, except that the count was little high, 15,800. Second time it was 14,300. Then other hemoglobin, ESR was 27. Sodium, all the TSH are all normal. Then among the biochemistry, urea, creatine, etc., we are interested in serum calcium, that is normal. CPK was normal. Cortisol normal. She's a diabetic. 7.3. And ANA profile was negative. Blood CRP was 7.3. Cianga was negative. Pianga was negative. IGRA means that is that what do you call this? The test for tuberculosis.
Interferon gamma release assay, sir.
Interferon gamma assay. Interferon gamma reactivation assay. That is a full term for that. That is negative. Calcium was normal. Angiotensin enzyme was also normal. So microbiology normal. Galactoman was also done for aspergillus, that is also negative. So they did an extensive workup. Element history of that's the past what I said. Diabetes mellitus. Diabetes. Okay, so what is the diagnosis now? What will you do now? Basically,
IgG4, sir.
that was not done.
That is
You
to be
want
done.
that? That has to be done. Okay. I'll give you it is negative. So in fact, I want to know whether what is this? She came with the diagnostic label of fungal meningitis. No, you want to we want to rule out that thing first. Nobody will ever make a diagnosis. So what do you want? So repeat MRI brain with contrast CT cut. That's what I did. This is a CT scan. Done, MRI done now. This is the T2 weighted, not much, nothing contributory. Bringing down the spinal cord, base of this, all thin cuts are taken. So I take the flare also, that is also not contributory. And this is the thin cut contrast called vibe sequence. From the below upward, see the look at the contrast enhancement of the dura and all. You can find it very clearly now. See the to the base of the skull, reaching the base of the skull, upper part of spinal cord. That is odontoid. See the basal dura is enhancing and thickened on both sides. Trival area is also enhancing. Meckel's area is enhancing. Parameter and tendorum is also enhancing. So in fact, the one test which they did not do previously was a proper contrast study was not done. That's a big problem. So this is the thickened dura. It's extending onto the hypoglossal canal. Then on the right side, unaffected side also, you can see the thickening of the thickened dura extending onto the glomus jugulaire, sorry, jugular foramen.
Slide notes in, sir.
Oh, not seen now?
Seen, sir.
Sir, we can
Yes,
see.
sir.
This seems
Is it seen now?
it is seen.
Yes,
Yes,
sir.
sir.
Okay. So this, I think we are on scene. I'll show the moment once again. This is the contrast study showing the enhancement and thickening of the basal dura. We'll pass forward. This is the thickening of the basal dura, extending into the hypoglossal canal and the jugular foramen, and the Meckel's cave and the foramen rotundum, and the pterygomaxillary fissure and the tendorium. I'll show each one later. Here, this is the thickened dura. You can see that going to the hypoglossal canal, under the jugular foramen, and that is a Meckel's cave where it is thickened. Compared to the left side, you see the left and right side. Right side it is enhancing, and this is a foramen rotundum which you see there, and this is a pterygomaxillary fissure that it is enhancing, and that is a tendril enhancement. In fact, our radiologist picked up there are many other findings in this patient, picked up the epidensity within that. He showed me this is a foramen rotundum and the maxillary nerve is thickened and enhancing. That's a maxillary nerve. I'll show that screenshot later on. And that's enhancing maxillary nerve. Difficult to make out, but I'll show that. And the CT base of the skull was also taken to find out whether there is increase in the size of the foramen. That is the foramen rotundum. That's the left side is normal, right side is increased in size. And look at the hypoglossal canal on the left and the right side. Left side is widened. Right side is normal size. So that shows that there's a chronicity of lesion. This pathology has been there for quite long. Now this is the this I'll show that's enhancing maxillary nerve there. The coronal cut, you can make out the dot-like thing which is enhancing. That is I couldn't make out, but he showed me, the radiologist showed me these are the maxillary nerve. And you can make out dilated foramen rotundum on the right side compared to the left side, and dilated left hypoglossal canal. So the pathology is actually chronic, not acute or 1 month or anything. It has been there for a long time. So it is something which is there for 2-3 years and which is remitting and lapsing like that with treatment. So what all possibility you keep in mind?
Sarcoid, sir. Sarcoidosis.
Very good. One possibility is sarcoid. Perfect. That is the thing we had to strongly kept that possibility in my mind. One more, the other thing is that IgG4.
IgG4.
Okay. So there is no erosion. You see that there is no like a infective cause like tuberculosis. There is erosion of the bone. It's a smooth enlargement of the canal. Something that chronically benign lesion remains sitting there for a long time. So actually, in fact, I asked the patient to bring out the old MRI 2 years back. So he brought a CD for that. I'll show that old MRI to you. This is, I think I'll skip this T2 sequence and I'll go to the 11 point. This is the prior. See, even the 2 years back, there was the bright spot of the posterior pituitary is absent. There is involvement of the posterior pituitary even at that time, 2 years back. And this is the contrast which is taken 2 years back. See, the degree of thickening of the spatial dura. This is another, again, from 2 years back. The dura is enlarging, enhancing. Probably the sinus was also involved at that time. That is why they thought it could be fungal. But that could be a dura surrounding the sinus itself. So this is the sagittal cut at that time. Yeah, sagittal. So serum IgG4, CT chest and abdomen. So I did a CT chest abdomen, which is normal. There is no hilar lipidinopathy. IgG4 is also normal. So what will you do?
Fetus hypertrophic pachymeningitis.
Yeah, most likely idiopathic hepatitis. So what will you do? Cefoterimol, methylprednisolone, followed by mycophenolate. Because this patient will recur again, so it's better to put him on mycophenolate. So that's the story of this particular patient. So these patients may remain indolent for a long period of time. With initially on attack, that disease is there still, it will not manifest. Sometime later they manifest. Just like this lady, 2 years back, she had one episode, improved. Sometime later, another kindness got involved. That also improved. Now got a different kindness getting involved. Okay.
Sir,
Any questions?
in case the patient does not respond to steroid and MMF, would you go for rituximab and higher therapies?
Yes, yes. Actually, in fact, I wanted to get a biopsy from that area, that's the maxillary fissure region. So, in fact, I discussed with my ENT colleague. He said it's very difficult to get from there. That I told the area which I wanted to do. That is the area. This is the area where we wanted to do the biopsy from. But he said it will be tricky, better not to attempt a biopsy from there. That's why I deferred. Because some of the IgG4 disease do require higher immunosuppressive treatment, including rituximab. That's a peculiarity IgG4. The percentage can be quite varied. Sometimes they respond very well, sometimes they do not respond. You have to go for high immunosuppression. Any questions?
Sir, there is an entity like polyneuritis cranialis where there will not be any pachymeningeal thickening or enhancement. Is there a condition like without
Yes.
any?
In fact, when I was there in Kottayam, I got along with Sangamitra. I did a study on polyneuritis multiple cranialis. See, at that time, these sophisticated investigations were not there. So all those polyneuritis cranialis multiplex, which it was published in the literature, that is all before the era of MRI and the what do you call, high level MRI and the contrast, etc., etc. So at that time, there is no entity called IgG4 disease. So all of the case must have been most likely IgG4 disease. And just like your Tolosacant syndrome, inflammatory pseudotumor, polyneuritis cranialis multiplex, recurrent second. So they're all basically more or less the same disease. The inflammatory steroid tumor, everything is same disease. So with the advancement in the knowledge, we have become aware of the ultimate pathophysiology and the antibody which are responsible. So that is why the polynuclear kinase no longer exists now.
But we do get.
In fact, this is, as you said, this is, as you said correctly, this is recurrent cranial polyneuritis.
Sometimes there may not be any pachymeningeal enhancement, but there will be
Yeah.
this thing also.
Yeah. Then I also seen cases like that without enhancement, real pachymeningeal enhancement, correct. But there may be some lesion there, which is not seen there in the MRI.
Yeah, maybe because of our
Yeah.
not picking up that. Sequences may be good, all those things.
Yeah. See, for example, that maxillary nerve enhancement, I cannot make it. I couldn't make it at all. But the radiologist was a very good, I do not know how to tell you, exemplary personality. He can pick out small things, he'll pick it up. Because his eyes are tuned to that. That maxillary involvement. Yeah, radiology is a good radiology is a must, and not only that, good sequences are must.
What is the vibe sequencer? Sir, use that vibe.
Vibe is the contrast sequence, which is a very thin cut, very thin contrast. Normally, people will not do the sequences because it goes on, a lot of time is required for that. And that much amount of time which has to be in the MRI, and money is also because. But our hospital does everything. Because when I ask them, they do that. For one patient, I had done 1,600 sequences I have done for one patient. And done the MRI 4 times in the MRI. Brought back each time, bringing back to the MRI machine. Done at various times. 1,400 sequences.
It's very difficult to have such a luxury in our place.
That's all depends upon you. See, this is not the luxurious thing, but you have to insist on that. Because we want to make a diagnosis, you have to go after the manager.
Total count was elevated, sir.
Pardon?
Total count was
Marginally elevated, about 14 to 16,000 is elevated.
There was also a history of CA thyroid post-thyroidectomy status was given, sir.
Yeah, even the discharge time it is given. But that is nothing to do with the present one, obviously. A malignant carcinomatous pachymeningitis, it should not be like this. Is a smooth enhancement, no nodularity in the pachymeningitis. That's the thing more likely seen with idiopathic pachymeningitis. Whereas those with secondary deposits, sarcod and all, there will be what you call something stuck onto the meninges. Some irregularity will be there, nodularity will be there. That's not there in this patient.
Okay, sir.
Okay, then we'll
sir.
close it.
Thank you very
So
much.
thank you. We'll see you next week.
Thank you, sir.
Good night.
Thank you, sir. Good night, sir.
Thank you. Good night. Good night.
Thank you, sir.